So thank you. I'm Anne Blandford. Most of you know me. I'm Professor of Human-Computer Interaction here, and I'm pretty confident I can now claim to be the longest standing member of UCLIC, as in I arrived here in 2002, and some of you probably weren't even born then. That's a guess. And I'm going to blame Enrico for the sheer clutter of this talk. It's an experiment. He said, what we'd like is something that kind of gives the broad overview of you know, all the kinds of research you do, and then perhaps gives a focus. So that's what I'm doing, a broad overview, possibly slightly too much, a bit of a focus, and then trying to put it all back in context again. And that means that it might be slightly chaotic at times, but we'll see how we manage. And it's gone back to not working again. Hey, sorry.
Just quickly click on here.
You'd have thought after all these years I'd have got this technology sorted out, but hey, one day I will do. Okay, so why do I focus on digital health technologies? Well, I guess I don't like dealing with simple problems. I want to deal with the chaos of real life. So health technologies are inherently demanding. They need all sorts of things. They need to be safe. They need to be engaging for people. They need to be effective. They need to manage our privacy. People are living in complex situations. They're managing complex health conditions, and there's lots of different kinds of users involved. And it's not like something like games where it's optional. We actually sort of don't have a choice, at some level at least, in dealing with, we certainly don't have a choice in dealing with health conditions when we have them or when our nearest and dearest have them. And we often don't have much choice about whether or not we use technology for that. And they're also used in lots of different places: hospitals, clinics, homes, out on the street, everywhere. And, you know, as well as the general, you know, in principle reasons, there's also the selfish reason. You know, at various points in my life, I'm going to want this technology to work well for me. Mercifully, I don't need to use it much yet, but except for well-being technologies. But, you know, we all have to engage with these things at various points in our lives, and we'd like them to be good and effective. So I've been at UCL for 23 years. I wasn't going to give you the whole life history. But when I arrived here, I was really working in two areas. One was on digital libraries, and one of my projects in that area was use of information resources by healthcare practitioners. That's what HCP stands for. And in parallel with that, I was also working on safety critical systems, human error, things where things go wrong and lead to catastrophes. And there was a point where I was thinking about the design of safety critical chocolate machines. And that didn't feel very credible. So I thought I would start looking at systems that were more genuinely safety critical. And obviously healthcare is a really important area for that. And so I led two large projects in that area called KaiMed and Eclipse. I think Eclipse, oh, when did it finish? 2018, maybe? But both of those, I was leading them, but I was having some difficulty getting heard by the clinical policymakers and clinicians because I'm not a clinician and they tend to just listen mostly to each other. And so for the last few years, I've taken the approach of not leading projects, but being the human factors or HCI lead, but taking the lead more generally from clinicians, i.e. it's clinicians who are generally leading the project. And that's had a bit of a weird effect because it means I don't necessarily choose the health conditions I'm working on or the particular focuses, but I'm providing the HCI input to an interesting, fascinating variety of projects. So that's a little bit of my history. It's really a case study on, if you're young, don't do what I've done. It's a really crazy way to run your career, basically. And I'll make that even more obvious in the next few minutes as I give you 5 very sketchy narratives looking at things from different perspectives. You know, I said I arrived and spent a lot of time looking at interacting with information. And I've also looked at how health professionals use technology, how individuals, often called patients, use technology, looking at the context within which these events are happening. And some of my work has focused on novel technology, particularly with people like Jeremy and Josie and Roxana and a few other people. So those will be very sketchy little tasters of different kinds of angles, ways I've looked at the world. And then I'll focus in a bit on technology for shared health management, which means systems where we're looking at technology and individuals, patients, and health professionals all having to work together. And then I'll try and kind of just reflect on that in the next steps. And keep an eye on me for timing, because I may not be good at this. So my first very sketchy narrative, I've been working on the idea of information and how we design systems to help us to find and manage and make sense of information for quite a long time now. And some of the outcomes from that have been this notion of an information journey that when I first started working in this area, people tended to think of information seeking as a kind of discrete activity that happened kind of when you went onto a web browser or when you physically went to the library or when you were going, oh, I'm looking for information now. But actually, that's not really what we do. We're really kind of doing other things, and along the way we need to find information, we need to make sense of it, we need to understand it and work with it. And with every bit of working with information, we realize that actually we still don't know it all, so we need to go and find more. And sometimes we just come across it serendipitously. And that was work that I did with Stefan Macri, where we were looking at how do we design systems that support people encountering information that's useful to them and not getting caught in these kind of information bubbles where you just find more things that are like the things you've already found and that reinforce your biases. And we made some progress in that area. We obviously haven't solved all the world's information problems, but hey. More recently, I've been looking at sense making and meaning making. And sense making is kind of how we understand the world or understand a phenomenon. And meaning making is about what that means for you as an individual. And so one of the examples is an MSc student, Julia Gomula, who looked at PCOS, polycystic ovary syndrome, and looked at how people made sense of PCOS, which is a poorly understood condition, but also how they understood it, constructed personal meaning about what having PCOS might mean for them, but also then finding what was normal for themselves, understanding their own relationship with PCOS. And Delisha, who hasn't made it over today, did something quite similar, but focusing on men's experiences of infertility and that journey of realizing that they weren't conceiving and trying to make sense of what that means medically, but also personally for them as a couple or as a family unit or whatever. And kind of finding their own new normal, and perhaps things change and that normal breaks down and they have to find a new normal. And it's something that I think we all live with in different aspects of our lives, not just in healthcare, but in many other areas of our lives as well. But specifically in healthcare, it can be very personal and quite kind of difficult and challenging as we get to understand ourselves differently and better. And so thinking about how we design technologies to support people in both making sense of the objective information, but also constructing personal meaning, which is very often about comparing notes with other people. Oh, I had this experience. What was it like? You been traveling a similar journey. What was it like for you? What can I learn from you? Can you learn from me? But also, how can we empathize with each other? So Delicia looked a lot at online forums and how men use forums to help to understand their fertility journey in particular. So that's one sketchy narrative, which I managed to take probably slightly too long over, and now look at it from a very different direction, kind of professional communities. You know, some of my information work has been with health professionals, and you know, one of the things we found with health professionals is that they develop communities of practice. I mean, I think we all do. But communities of practice around understanding information resources, around understanding their work, sharing information, building understanding. And, you know, again, Josie's been looking at some of those ideas in the context of ophthalmologists and optometrists sharing understanding and learning from each other. I've also looked at it at professional work from different perspectives. Distributed cognition has been one of my themes over many years, including studies in surgery. This is a photo that Eric Berndt, who was an intern with me several years ago now, he took while he was working in anesthesia. So this is the anesthesia side. Over the blue thing is the surgical side, where the surgery team are actually doing the operation, and looking at how people use the different technologies and how they communicate around the room in what is a much larger team than what you can see there. And the picture at the diagram at the top is, again, from one of my students, Atish Rajkumar. When he was actually an MSc student, he went into intensive care at UCLIC and looked at how people communicated. And that's just one of the simpler diagrams that shows, how different people within a clinical team communicate, including the patient and other nurses and doctors in that process. I've spent a lot of time working on patient safety and errors and resilience, where a key idea about resilience just about putting barriers in the way to empowering people to create the best possible solution in this context. So it's not just about stopping bad things happening, it's also about making good things happen. And sometimes that gets lost in the human error literature. And I think I'll stop there on that one. Well, no, I will just mention work as imagined and work as done. That work as imagined is what's written in the clinical protocol. This happens, then this happens, then this happens, and we do so and so. What really happens with work as done is what works at the time. You go to the pharmacy, you ask for a litre bag of some medication or other. They haven't got a litre bag of some of that medication, so they give you 2 half-litre bags, and then you have to work out how to program the infusion pump to program 2 half-litre bags instead of 1 litre bag. And it's a small workaround, but each of these workarounds kind of creates potential for things going wrong. And so you have to think about actually how do you make the system safe while also accommodating the real work of what happens as opposed to the imagined work, which is what should happen. So we've worked with clinicians. We've also worked with the people that I'm calling individuals, but most people, they're generally referred to as patients. And we've looked at things like the patient journey, which fits kind of with the information journey, that people's lives are evolving and their understanding of their lives are evolving, and that they're often going through phases of intense learning, and then they live with a condition. So you see some of the same themes are coming through on different slides here. So this is a diagram that Ellie Burgess produced in her study of looking at chronic kidney disease, that very early on, somebody's told that they've got kidney disease and they go, oh my goodness, what does that mean? What is it? How did I get it? How do I deal with it? What decisions do I have to make? Huge amount of learning having to go on at that point, leading up to a treatment decision. Are they going to be put on a transplant registry? Are they going to go on hemodialysis? Can they manage it with medication? Do they need to go on, peritoneal dialysis? So they have to make decisions, and then they gradually learn to live with their condition, and they perhaps need less information, but they're also having to manage information. They're having to often keep up to date with new literature, or some people choose to keep up to date with new literature. Others choose to kind of go, oh, I'm going to pretend this isn't happening to me, or I'll live with the minimum I can get away with. But then there might be a big transition, the treatment that they've got isn't working anymore, or the possibility of a transplant comes up. And so they suddenly have to learn a whole load more and make more decisions about their lives. And we have to think about, how do we actually help people to make sense of the situation and use technology perhaps to help them to make sense of that situation without making them feel completely overwhelmed, which is often an experience. And then, of course, they will continue to live in that new state, and other transitions of similar kinds might happen over time. And in terms of digital behaviour change interventions is what DBCI stands for. I've done a few projects around that. One of them was with the Africa Health Research Institute, and this is just a screenshot from the app that we developed with them. I would say we were brought into the process slightly late, and they'd already made a lot of decisions. And so it actually never became quite as engaging as we had hoped that it would. But we learned quite a lot from that about what it takes to make an app engaging and informative, as well as being privacy preserving, which was another concern for us, and safe, helping men. In this case, again, it was a project of focusing on men who are more reluctant to engage with HIV treatment than women tend to be. And so we were focusing on how to engage men and how to make them feel more comfortable about going to a clinic and taking antiretroviral therapies and whatever. Some of it worked quite well, some of it was a bit disappointing. But I don't have time to talk through all the details. So part of that, part of the challenge is that people don't live in isolation. They are living in communities. We're all living in communities. Why am I saying them when I mean we, all of us? And, just like in that context of HIV, what people do is often very influenced by what their peer community, what their friends, their family, what they believe, and what they will find comfortable and acceptable. And, we found very similar kinds of things in Ghana. So the photos are photos that I took in Accra a couple of years ago now, kind of emphasizing the fact that people are they're living in communities, they're working in communities. I've no idea what all these people were meeting for on this occasion, but I was careful to take the photo from an angle where hopefully I haven't identified anybody. This photo is a pharmacy. You can't read the signs, but it's one of those container trucks that's been adapted into a building, and it has the little signs say things like, come for your pregnancy test here, come test your blood sugar here. I can't remember what the other ones are, but they're about what are the services that this container truck that is also a pharmacy is offering to people along with the medications. And so people are, they're living in a community, they're learning from each other, they have a social identity as a particular kind of person. In this case, we were actually looking at type 2 diabetes. So I also have lots of photos of shops where they sell nothing but fizzy drinks and sweets. Or people with baskets on their heads just selling fizzy drinks and sweets. Which is one of the contributing factors, obviously, to type 2 diabetes. And we did a study where we interviewed a lot of people. When I say we, local researchers in Ghana, we worked together to design interviews, and then they conducted them. And we asked people about their use of mobile technology. We asked them about information seeking. We asked them how they found out about different things, how they dealt with health management. And it was all looking really positive. You know, well, why don't we, as part of an intervention to help people to manage diabetes, why don't we kind of design an app to help people to think about it? So Ethan Gray, who was an MSc student a couple of years ago now, he went out to Ghana and kind of started to gather data around this notion of developing an app with them, and came back and went, and it's not going to work. But health information, they want health information from people they trust, from their seniors, from their community leaders, from health professionals. They don't want to look for it on an app. So we had to do a rethink. So, you know, actually accepting that technology isn't always the answer, but understanding that technology might work for those leaders and help them to build their understanding and to keep in touch with each other and to kind of use it as a communication mechanism. But actually individuals don't want to, they don't want to read on their app about, you know, how you manage your blood sugars and how you do this and how you take physical activity and what foods to avoid and all that kind of stuff. So the project finished before we had time to actually finally test it. But I think even knowing that natural assumption that if people use phones, if they look for information, if they can afford the data download, then it will work, it kind of undermined that assumption for me. And also, I think it's a more general assumption that is made. Oh, something's happened. So what's happened is that a Zoom window has appeared over top of it. When I was younger, we used to joke that you had to have a 9-year-old in the house to use your technology. Thank you for not being a 9-year-old and helping me to use the technology. I had just finished that slide, so yes, I was trying to move on. So my final one of these kind of very sketchy narratives, which has taken me far longer than it should have done, is about novel technologies. There's a lot of talk about, you know, introducing disruptive technologies into healthcare, whereas in HCI we often talk about co-adaptation. You know, the people and the technology learn to work together and they adapt to each other over time. But it is disruption. Sometimes it's positive disruption, more often it's negative disruption. But I think one of my important perspectives in this area is that new technologies provide a new way of seeing, particularly in clinical contexts. You know, the top photos, one from a study that Niels van Berkel did as part of the WISE community project that's recently finished. You know, you can see the polyp better by having your attention drawn to it. And he looked at lots of different ways of inspecting polyps. The middle one is linked to Josie's work, but it's just an easy image I could steal. That's looking at artificial intelligence, helping to look at optical coherence tomography, photos of your eyes, basically, complicated photos of your eyes, in a different way, and using AI to help to draw people's attention and help people to make decisions about eye care in that case. And the third example is from Sujong Yu's work of using augmented reality to support liver surgery. And I'm hoping that Jeremy and Roxana will give a presentation that's slightly less scatty than this one about their particular projects in this general space. And the diagram at the bottom is taken from a Tochi paper that says that basically for any clinical phenomenon, clinicians are trying to understand the real world. But when we introduce computers, we have a computational representation, like all of those, which processes them to give you a computational outcome, which then needs to be interpreted back by the human team at the other end. You know, the blue circle, that's suggesting there's a polyp there and you might attend to it. The diagram in the middle, that's highlighting some features on an OCT scan that might help with interpretation. This is highlighting blood vessels within the liver, and there are implications from that. Can the clinician interpret them correctly? I talked far too long on that. I'm going to have to skip some of the rest of the slides. But in the remaining half or 20 minutes of this talk, I'm going to look at a specific part of this space, which is not right at this end, where the patient is often unconscious, and therefore we're focusing on the clinical team and their work, and not right at this end, which is where people are sort of self-managing, checking their steps every day, or trying to manage their diet or their sleep or whatever. That's actually photos taken from Couch to 5K, which is a learn to run app. And I'm going to focus on this bit in the middle here about shared care, where both clinicians and patient individuals are involved one way or another in the clinical process. So I'm going to intentionally skip those slides and look at 3 different case studies. The first case study is at that clinical care at home end. And we did a study on basically on infusion pumps. This is an example infusion pump at somebody's bedside at home. And how infusion pumps were used when they were in people's homes rather than in a clinical setting where there would always be medical staff involved. So this is, if there aren't medical staff on hand 24/7, how are these things used? Well, the source of data we had was incident reports from the National Reporting and Learning System. And we had a very large corpus of data, and from these, 606 of the reports were about incidents where things had gone wrong at home. And we analysed them in various ways. One was, how is the patient talked about? So it was a surprise to us that in a third of cases where people were plugged into one of these devices at home, the patient was only described as an object. You know, the patient was there, the patient was lying on it, the patient looked pale or whatever. Third, they were an object. In a third of cases, they weren't even mentioned at all. It's like they weren't there. And only in a third of the cases were they actually described as playing any kind of active role, the patient or any member of their family. You know, the patient rolled over and obscured the line so the drug didn't flow to them anymore. Would be an active role for the patient. So patients really weren't very much in the picture at all, which surprised us given that these devices were at home. We did an analysis that looked at actually how did the clinical staff, when they visited, how did they troubleshoot it? You know, so obviously initially a clinician has set it up, they run it, maybe there's some interaction with it, the whole thing fails. Then when a clinician finds out, they have to diagnose it, fix it, and hopefully learn from it. And we looked at what they were doing in that setting. But because the clinicians aren't there all the time, they're either called back when something goes wrong, or they're not even called back. It's just the next time they turn up for a routine visit, they see that something dramatic has happened and it's not working the way it should. You don't really want to be in that situation. And you know, one of the conclusions we drew from this study was the devices are they're physically in the home, but actually they're only part of the care system. The family and the patient are not really involved. They're kind of excluded from this. And so the device, in this case, the infusion pump that's delivering palliative care, is attached to the patient, but it's only used by the nurse, and the doctor is always involved remotely. So there's no remote monitoring. The care system is designed for routine care. It's not designed to really think about what happens when anything goes wrong. And I would argue from that we need to rethink the design. In this context, we need to rethink the design of the care system and possibly the technology that supports that care system in terms of how we deliver effective palliative care at home and how we train people to do it. So, the infusion device is one product, but maybe it needs to be wirelessly connected to other things. There are many, many things that we could do to make that system.
The family not connected to the device. The question of nobody thought about it. The device is too complex, require or privacy or a combination of them.
I think actually there is a different answer, which may not be the one you want to hear, which is about safety. So these devices, if you know how to use them, you can change the rate of medication, and the clinical team feel that they're responsible for the medication rate, because if you overdose, you're going to hasten somebody's end, and if you underdose, they may be in more pain than is merited. And so I think the primary issue is around safety, and they don't want the family to be too involved because the clinical responsibility lies elsewhere. There are also issues around, the family not being trained to use these things because it's often very short term. It's only maybe a few days or even just a day at the end of somebody's life that this technology is brought in. And there is a learning curve to learn to use it, but I think the primary reason is around patient safety and legal liability for anything going untoward in the process. But nice question, thank you. So my second example is much more about shared care, where the patients do have a significant input into the process, and where there is a much better designed system for troubleshooting and for supporting the patients in managing their own health. And that's in this case, it's hemodialysis. So people with kidney disease, advanced kidney disease, often need to go on hemodialysis to clean their blood, to kind of keep their kidneys going, basically, and to give people any quality of life at all. And it typically takes about 4 hours every alternate day. A lot of people go to hospital or a clinic to have that treatment regularly, so it kind of dominates their lives. But some people have it done at home, and they do it themselves without direct clinical support on a daily basis. So they're trained, and they're trained for quite a long time to do it. And again, this is one of Atish Raj. This is Atish's PhD project rather than his MSc project. And he did an observational study which led to a set of models of actually how this system works, and thinking about how we might redesign the technology to be slightly less daunting to use than that picture up there. And one of the representations he created was thinking about how the system communicates with the technology, the patient reading their own physiological signs as part of that is really important. They think about how they're feeling, and does that mean the technology is working properly, or does it mean something's going wrong? The patient is often supported by people at home, and then there are different people who are outside, but who are available at certain times of day. And there is a doctor, but I've kind of grade them out because their role is relatively minor in all this. And, in thinking about this as a home care system, we looked at how they learned to use the technology. As I said, they receive extensive training, but nevertheless, you know, there's a huge emotional load in this. Most of, you know, well over half of the people who were interviewed described being scared or panicking. How did I work that out? I just did a word count on the words scared and panicking in the transcripts. Nothing sophisticated there at all. They reported making mistakes. Sometimes they learned from their mistakes, sometimes they didn't. But they also learned informally, often not from each other, but if they worked with a different clinician, like if they ever go on holiday, which as you can imagine is quite hard if you're reliant on a machine that big, they would have to go and dialyse in a hospital at the other end, even if they were dialysing at home on their own in the UK. And so they would learn from people in the hospital on the rare occasions that they had hospital dialysis. But also importantly, you know, they're not living to dialyse, they're dialysing in order to be able to live. And so they fit dialysis into their lives. We had some hairy accounts of people making do and mending, like taping up pipes and using a hairdryer to fool the machine into working when it didn't want to work because it was a bit damp in there, and reprogramming things to trick the machine into working when all its safety mechanisms were set up so that it wasn't going to work right now. And people also choose quality of life. So this photo is of somebody's dialysis machine. That's a much simpler machine than some of the others, but it's sitting on her balcony outside so that she can dialyse in the outdoors, and she has a heater there to keep the solution in there at the right temperature. It's not in the manual. The manual doesn't say you should do this out on your veranda. It says you should do it in an enclosed space that is clean, no cat hairs, you know, all those things. And somebody else speeds up the machine. So, you know, what people really do is not always what it says in the textbook. And so there's, you know, people do co-adapt. They learn to live with the technology. The photo is a dialysis machine hidden behind doors in a cupboard because people don't really want to live their lives around it. They want it to be hidden away, and they want to get on with their lives the rest of the time. This system is designed for training people, for troubleshooting, much more so than the palliative care system. But there still wasn't much support for remote monitoring. So my final case study is about COVID recovery. Sorry, if any of you want to stand up, do feel free to kind of stand up and move around. I'm having a drink. So Enrico and I have been involved in this project over the last, feels like forever now. Actually only since 2020, obviously. You know, we all remember, well, I think we're probably all old enough to remember, you know, the trauma that was the start of COVID-19. And we started this project really early on, kind of May 2020, which was or even April 2020, actually, where people in hospitals were becoming aware that they were discharging patients who were still, you know, from intensive care back into the community because they needed to release the beds, and those people were not really fit to be in the community and they needed a lot of rehabilitation. And so, you know, we worked with a team of clinicians and a company called Living With to develop a system that involved an app for the patients and a dashboard for the clinicians to develop supported self-care where the support was provided by the clinics, by what became long COVID clinics, but of course weren't in April 2020 because nobody had even heard of long COVID at that time. So we were trying to deliver an app, a dashboard and a care pathway that would work for as many people as possible in that situation. And we've just had a paper accepted on the chaos that was this project. from an HCI perspective. We've had papers accepted on the clinical side and the health economic side and other things, but this is the HCI one. So the system was designed for clinician-supported self-management. Our idea was that it would be more motivating if clinicians were involved in supporting their patients, but we did find that that required the clinicians to be motivated to get their patients to use the app. The condition was poorly understood, so we felt it would be safer to work with clinicians because we didn't really, we didn't want to just hand people an app and just go, oh, go sort it out, because we don't, long COVID wasn't well understood. Though there was a significant demand for a self-management version, and that has now been released, but we're not directly involved anymore. So what do we do from an HCI perspective? Well, it was an agile development process. You try finding much information about agile development in healthcare with HCI. Doesn't exist. But anyway, we've released nine versions of the app. The first one was in August 2020 with 32 patients, and by 2022 it was being used by 5,680 something patients. The design drew on behavior change techniques from the literature. We captured the requirements in personas and scenarios. The personas came from medical students who were in contact with patients. So we couldn't access patients directly. We had to rely on medical students to describe their patients to us. We had a lot of engagement from public and patient participatory people, often who had COVID themselves, but were not officially users. And they worked with us in a variety of ways, including co-designing some of the information materials and evaluating some of the early versions and features of the app. I spent 18 days being Doreen, where Doreen was an app user. I usually did it by having a glass of wine and then using the app in the evening, because that meant I had slight brain fog as I was using it. And that was all recorded, because we couldn't ask a patient to do that, but it was designed for longitudinal use. So I think there are real questions about how do we evaluate systems that are being used over an extended period of time, especially when the users are really debilitated. But we interviewed some of the clinicians who were actually using the system, and eventually we managed to interview 12 patients out of 5,000 and something. We got 12 to participate. So I'm not going to go through the detailed design of the app, because you'll all fall asleep and it's nearly 4 o'clock. At the beginning, the app user was called Colin, then it became Doreen, and now if you want to see the app, I've got it on my phone, and it's now Craig. I don't know why the name keeps changing. Anyway, there are features to do with, there's a library somewhere. People can set goals. They have these cards that suggest what they might do today, and they can message their clinic and hopefully get messages back as well. At the beginning, the app had 5 things that people could kind of measure for themselves, quite an extensive library. A lot of effort was put into that, and a diary that supported for them to record their levels of fatigue through the day. And 2 years later, this is the final version of it that we worked directly with before the money ran out. And we had patients were able to fill in about 11, I think it was, questionnaires tracking their symptoms. These are clinically validated questionnaires, the only kind that medics will work with. We developed some therapy programs. They're over here, around fatigue, stress, brain fog, breathlessness, etc. They could manage medication, and they could now record additional symptoms, because however many symptoms you you enabled them to record, they would always have, you know, there is such variety in long COVID. I think we've had about 200 different symptoms reported through the app. All sorts of weird things, you know, things that you wouldn't expect will be part of COVID. And you know, the clinicians developed a patient pathway. I'm not going to go through all the details, but you know, somebody comes along, they get assessed for suitability for the app. This number 6 is the only one that talks about app use at all. They're discharged after 12 weeks. That doesn't happen. People don't get better that quickly. And then they're meant to self-manage. Again, that does happen a little bit, but not very much. But anyway, this is all the advice that clinicians were given about how to work with the app with their patients. Not very much advice there. I mean, I think one of the positive things is it has had an impact. We're still trying to understand exactly what that impact is and how people really used it. But you know, it was used. You know, in the time of the project, it was used by over 5,000 patients. We were aiming, when we started the project, when we applied for funding, we were hoping we might get 5 clinics involved and maybe 1,000 patients. And we actually got overwhelmed by the number of clinics who we found we were working with and the number of patients who were involved in the app. We still need to uncover what meaningful engagement is. We still need to evaluate the clinical outcomes and particularly how we might help people to learn to self-manage better, because we started thinking this condition was going to go away within a few weeks, and you know, people are living with it for years now. So you know, our thinking about it had to change, and perhaps we didn't change fast enough. It was very hard to engage with real users. You know, they were suffering from so many things. Their lives were so challenging on the whole. We didn't even try to get longitudinal data from them. This is why I resorted to being Doreen. The patient and public participation people and clinicians, they did provide some fantastic input, but inevitably it's incomplete because they're not people who are living with the condition using the app on a day-to-day basis over weeks and months. Patients are more diverse than we can imagine, particularly long COVID. An awful lot of the patients were health professionals, you know, because of the situation of that these people had more contact with COVID. So they had high health literacy, often quite high digital literacy. They weren't kind of people who was, but we also had people who had low educational levels and low digital literacy, and so very, very diverse users. And we had to kind of find a balance between providing features for all these different kinds of users without creating an overwhelming experience. And we'd hoped the clinics would really help with that, and they were also feeling so overwhelmed that they, on the whole, didn't. Every clinic was different. 35 clinics, 30 different care pathways. Impossible to design for 35 different care pathways, or even more if we'd worked with more clinics. We co-designed the app with the first few, but of course you couldn't keep doing that with every single clinic that came on board. We found that we designed the app for patients and the dashboard for the clinicians, and actually they needed to understand what each other were doing, and we didn't pay enough attention to that. So that was, for us, a kind of oops moment. And the importance of onboarding. Clinics didn't necessarily onboard patients beyond the technical. You know, there's this app, here's your login details, dear. Now go and get on with it. They didn't kind of give people enough information about, you know, why they would use this, what they would do with it, what the clinician was going to do with it, how it was going to help them in the longer term. So I think I'm going to skip that slide as well, and just go onto my reflections, which is, you know, I'm still on a huge learning curve on this. But looking to the future, you know, taking all these different kinds of, I realize I've probably overwhelmed you with case studies. Blame him. You know, generally, clinicians, patients have different expertise, they have different values, they have different motivations. Trying to design technology that works for both or that bridges the differences between both and creates common ground between them is, I think we don't do it very well at the moment. It's an HCI problem, I would argue. We need to make safe adoption and effective use as easy as possible. Sometimes you can't just kind of hand something over. You can't hand over a dialysis machine and go, here, dear, this is easy to use. Just walk up and use it. It's never going to happen. But some other kinds of technologies, they should be as simple as possible. They should be easy to use safely and effectively. And I don't think we do a very good job of that. Onboarding is key to success. You know, introduce up to speed on stuff, whatever kind of health technology it is. And we also need to design for troubleshooting because stuff doesn't always work the way you think it should. There's huge hype about the value of the health tech market. You know, health tech market is going to be worth so many billions in the next 5 years. And so there's a huge investment in this area. This kind of idea of a valley of death between, oh, we'll just pilot something and show it works fine with 5 users, and deployment at scale. You know, I've tried to talk about some of the challenges of actually doing that. So health tech can be transformative, but it really needs to be better designed to be user-centered, to be inclusive. You know, it's not optional. It's not like, you know, I don't know, a cockpit for pilots. You know, selected people become pilots. Everybody gets ill every now and then. So design has to be inclusive for as many people as possible. Care delivery needs to be user-centered. That's not really an HCI issue, but technology should be supporting that. Tech design and care design need to be aligned. I think we can do this stuff better. I was going to talk about my own work, but I'm not going to do that now. So thank you for listening. Thank you. Nobody fell asleep.
Great. Yeah, thank you very much for this great talk. I think we have a little time for some questions. So are there already some questions? I'm gonna walk around and I have an extra microphone.
Wonderful talk. Thank you so much. I'm working in healthcare and we did a longitudinal deployment on the smell care project for 6 months. Various levels of success. My question was, you briefly touched upon the topic of engagement. What makes successful engagement, meaningful engagement? Can you elaborate a bit more on that? What is engagement, in your opinion, with healthcare and apps at large?
Yeah. Thanks. It's okay. Thank you for coming. So I think the word engagement has multiple meanings, as you will have realized. And in kind of other areas like gaming, it's relatively simple because, you know, are you engaged with the app? Do you want to come back and use that app again? You know, me, I'm completely addicted to Sudoku. It's really sad, but I try not to spend hours a day on it, but you know, and it's at one level, it's optional. Am I engaged? Am I engrossed in it? Yeah, and the same is true for all of us, probably with the, you know, we all have things where we get very engaged with. Whereas, I mean, health technology isn't so inherently engaging. I mean, even if you try to gamify it, actually there's an underlying important purpose to it. And I think if you make it too much of a game, you can lose the underlying purpose. And actually what you don't want is engagement with the app. What you really want is the app to be a vehicle to help you to engage with the therapy, the intervention, for what it is you're trying to do, or indeed the self-acceptance and the learning to find a new normal that is, helping you to live your life more healthily, more positively, etc. And I think quite a lot of apps actually in the health space, you don't want people to keep using them forever. You want people to learn to self-manage without them. So they are there to serve a purpose and to empower people to grow, and to learn to do things without being reliant on the app. So I think the word, I used the word engagement, and maybe it was a dangerous word for me to use, but yeah, it's about using tech in a way that leads to the right kind of positive outcome, which is not actually about more using of the tech in a health context. It's about acceptance of the condition, or managing the condition, or getting better from the condition, or whatever it is.
Thank you.
So good luck with your smell therapy.
There's another question by Yvonne Rogers in the chat. Since starting your research in digital health and now, do you think more clinicians are more aware of the importance of the need for HCI? If so, how do you know?
So I think the answer is still that it's patchy, that there are clinicians who do. I've been able to run the last several years of my career being involved in a lot of projects in the digital health space, all because people have come to me and gone, we recognise we need HCI in this project. Will you join us on it? And sometimes I've said yes, and sometimes I've said no, I'm over capacity. But there are also still you still see a lot of narratives that basically say, oh, we're technologists, we're building this, we need to talk to the clinicians about what they need. And I think failing to recognise that clinicians aren't HCI experts, often their understanding of their own work is tacit. They become experts. They don't know what it is they do. They can't articulate it anymore. Or maybe they never could articulate it. But, when you're an expert in something, it's really hard to unpack it. And so I think it is, hello, Yvonne, it is getting better, but much more slowly than it ought to. And it's still really patchy. So I've worked with some amazing clinicians, and I've really loved working with every single one that I have worked with. But there's also an awful lot of clinicians who would have benefited from HCI who aren't interested and don't believe it matters at all.
I might also have a question. So you've talked a lot about different stages. So needing information at the beginning, living with it, having this connection between the patient and the clinician, and who's not involved, etc. Where do you think are the most important questions to be asked? And also, what about the current landscape of technologies or other approaches are you most excited about?
That was a lot of questions there. So obviously AI is going to have a huge impact, whether we like it or not, whether we think it's good or bad. I mean, that's very simplistic. There are places where AI is, or the modern forms of AI based on kind of computational statistics and ML. There are places where it's going to have a huge impact, and other places where actually it's not right. It's not going to work well. It can't. I don't know how long it'll be before it can deal with the complexity of healthcare. I think we do. You asked, where do we need to pay more effort? I think we do need to start to learn to reason better about complexity and about how to manage the complexity of these relationships and these conditions and the emotional aspects of it. Oh, Nadia's even gone and I'm still talking about emotional aspects. You know, healthcare is not just about physically do things work. They're also a lot about not just mental health, but just, you know, treating people as whole people, people feeling cared for, people feeling whole human beings. And I think technology has a role in that, but technology can't do it all. So it's about understanding where technology can work and where it provides something really positive and where actually it needs to be complemented by our skills. You know, when I visit my mum, you know, I give her a hug and she's small and bony and sits in a chair now, but, you know, a hug still matters, and no technology is ever going to give my mum a meaningful hug in the way that I do. And, you know, yeah, technology can help to track, you know, her temperature or her weight or, you know, other things that tell us about her health. But it can't deal with all aspects of care. Was that did I answer enough of your question then?
Thanks.
Ewan.
Thanks. I love the examples of the safety critical systems that you gave. And I was wondering, do you think that the way safety critical systems has changed at all since you started researching them? And has the impact of kind of user-centered design trickled down to the design of those systems too?
So I think attitudes or the discourse has changed. You know, I'd love to think that we've played a very small role in that, but, you know, bigger roles have been played by people. Oh, sorry, names are going out of my head. The guy who talks about the just culture, you know, in healthcare, that what you shouldn't blame is the person at the sharp end who appears to have just made a mistake. Well, they've probably made a mistake because there were all sorts of layers behind them and pressures to work under certain conditions. And there's also what for me was a very formative book by Charles Vincent and Renee Amelberti. On page 29 of that book, they've got a lovely diagram where they talk about 3 kinds of safety. One is that the first one I talked about, you know, put barriers in place to make sure nothing ever goes wrong. The second is what I call resilience, where, you know, you empower people to work together and build teams and get better at doing the job and learn to do things more effectively. So you're working within kind of a safety envelope, but where you're concerned with things working well as things working badly. And their third category is, which I haven't even thought about the role of technology in this, is about really expert users. So, you know, the guy who did the first heart transplant, you know, nobody had ever done this before. You have to think about how will you keep this patient alive. Actually, in trauma and, you know, complex health contexts, the clinical team are often having to do something they've never tried before. They've never done, and they just bring the expertise that they have from related areas and apply it to this new situation, and hopefully the patient will come out a bit better. And, you know, to put it really horribly, even if this patient dies, they will have learned something through that process. And the patient, you know, if the patient dies with all these interventions, they would almost certainly have died anyway. You know, that sounds awful, but, you know, there is that level that healthcare makes progress. Indeed, many other domains make progress. You know, when they first started flight, you know, there were some pretty awful crashes, you know, before we managed to get planes that actually stayed in the air for any length of time. You know, so one has to go outside the envelope and accept the fact that sometimes things will go wrong. But those should be in the really novel situations, not the, oh, this person has a broken leg. Let's do this brand new experimental technique on them that involves kind of pulling out all sorts of bits of their body and putting it all back together again. Because we've worked out how to deal with broken legs now, you know. Sorry.
Is that as fun though?
It may be less fun, but it's probably better for the patient.
A question about what you said at the very beginning of the talk. You mentioned a very sort of autobiographical perspective, and I think you said that you were going to tell people not to follow your example. So I'm feeling worried about that. Apart from joking, though, I was curious. How did you get into digital health to start with? Because you said what the projects were, and it seems to be all UCL projects. I know you were an academic before getting here, but just out of curiosity, how did you end up there?
So it is a very good question, and I gave half an answer earlier in that I made a very specific effort to get back into healthcare for ChiMed and Eclipse because I was doing this work which I facetiously called safety critical chocolate machines. But actually at some level that was true. We were doing systematic user analyses of chocolate machines to check that they were safe. And that felt a bit... Sorry?
What is a chocolate machine?
What is a chocolate machine? It's one that dispenses chocolate.
Okay.
A vending machine, yeah. A vending machine is perhaps a more helpful term. So I, you know, at that point I got back into healthcare very deliberately and found people like David Barber, who is now retired but was at UCL in the School of Pharmacy. You know, as we were thinking about what's a relatively simple unquote medical devices that will allow us to reason about human error and patient safety, but that are real and meaningful. So David put me in touch with Bryony Dean Franklin, and so, you know, Bryony and I basically put that project together with Anna and Duncan in UCLIC and people at Swansea and people at Queen Mary and people in various hospitals. Just because I was trying to work I was working in safety critical systems, and I was also, you know, we were trying to do stuff in control rooms in parallel. And then I realized that you couldn't work in healthcare and in other domains and stay sane. Or many would dispute the notion that I'm sane anyway, but I've been even more bonkers than I am. But the first time when I got into the kind of digital library stuff, I think it was actually Harold Thimbleby who was trying to build up research in digital libraries, and he kind of encouraged me to work alongside him in that. And we just happened to find clinicians who were introducing digital libraries into the Whittington Hospital, it was at the time, and it seemed like a really interesting case study. So a lot, it's half serendipity and half deliberate.
Thank you.
And I think all research careers are half serendipity and half deliberate. That is a universal truth.
Questions? So then let's thank Anne again.